Hi, welcome to my podcast. My name is Dr. Brendan McCarthy. I am the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. Thank you so much for tuning into the podcast. As always, I love having you guys here, and I've been looking forward to this week's episode because we're heading towards the end of this discussion on migraines, the series that I wanted to create in it. And the first section we talked about, estrogen, then we talked about progesterone, and now I'm going to talk about lifestyle, diet, and just a couple of genetic things in here. With that said, there was a question that was posted on the last episode that was posted on one of the reels on Instagram. And the woman who posted it gives me a window to discuss today's episode a little bit more clearly. And I normally do Q&A sections at the very end of the series. So at the very end of the series, when everyone's watched all the videos, I look for questions that are good ones that I can share that seem universal. And then I would do one video specific to that. This is not that video. This is me wanting to talk about lifestyle and wanting to talk a little bit about genetics, how that contributes to migraines. But at the same time, her question, just like I said, it leads into this really well. So bear with me with this. It's a very complex thing I'm trying to communicate. And I've said this, I want you to hear me. Medicine is not impossible. If I went to your place of work and tried doing your job straight away, like whatever you do, if I came into your life and tried to do what you do, I would fail. I would fail miserably. But over time, I have faith I could learn how to do it. So say you're working in a job and you're doing real estate, or you're an advertising consultant, or you are a school teacher. My first day on the job, I would not do a very good job if I just tried doing it straight out. But over time, with being trained and being explained to, I could learn to do it. Medicine is just like that. A lot of people in this industry, and even not in the industry, will constantly make it seem as if we do magic and unfathomable science. And I want you to know that is not at all true, not even close to true. It's just a discipline. It's just a dedication of time and focus. And it's also the way you communicate it with people. That's my job. I always want you to know, I want to communicate clearly with you, because that is what is the single most important thing in medicine, I believe the doctor does, is communicate to the patient, this is what I see. Then we put together a protocol. I'm trying to communicate with you something that has a lot of moving parts, and it is complicated, but it's no more complicated than anything else you know how to do. It's like if you were to drop you off somewhere in your neighborhood, you knew how to get to your home, you know how to drive home. You know, avoid this one road because that's going to have high traffic. You know, this has the traffic light takes forever. You know how to navigate your streets. It's like that. So I'm trying to figure out the best, most cleanest way of communicating this with you. So this was posted last time, and she posted, Gina TZN posted, I'm not sure I understand this reasoning. During migraine, the blood vessels are dilated, which is why we feel the pain. Medications prescribed to treat the migraine are triptans, which constrict the blood vessels and can help reduce the inflammation and pain associated with the migraines. This is in terms of me saying when you're doing oral contraceptives, you should not take oral contraceptives when you have aura, migraines with aura, because your chances of developing a clot and having a coagulation, a pathology with coagulation are much higher. She's not wrong. She's not wrong. But it's confusing, and this is why. Migraines are previously, up until a few years ago, understood to being a pathology associated with dilation and constriction in blood vessels. And so dilation of blood vessels, excessively dilated, they believed caused migraines. Though I want to point out, migraines with aura have a constrictive component as well. Okay, there's a constrictive component as well for migraine with aura. That's why you should not do your oral contraceptives with that, because estrone is elevated, as I mentioned last episode, in creating that higher risk for a clot, because estrone elevates, creates more thrombin, and you have a vasoconstriction. This is not a good combination. That's not, it's like trying to push it through a smaller aperture. You're going to have a problem with that blood wanting to coagulate then. So step back for a moment. Let's think about this. There was nothing wrong in the woman's approach and her questioning. That was completely logical, completely right. The thing is what I want to point out is like, I don't give someone the Triptan class of medications to dilate out their vessels or constrict their vasoconstrict their vessels. It's more complicated than that. The understanding the theory or the reason why we have migraines, it's important not to put the observations we have to be the cause of the problem. This is strange. What caused the blood vessel to constrict? What caused the blood vessel to dilate? What caused that? Was it dilating is what caused the pathology, or was the dilation just something that occurred along the same time with and just happened concurrently with it? We understand migraines a little more different now. In the past few years, the research is showing it's more neural in nature. There's a pathology there. They're still understanding it. So the thing is, do I wait until I understand what the ultimate understanding of why a person has a migraine or migraine with aura? Do I wait till they have that final study that shows the final, we know now why this is, which percent? And the answer is no. We work with what we have. We work with what we know. Why this question came up? Why am I asking this? Why? I'm not going to prescribe you a Triptan class of medication. I'm not going to treat the serotonin pathway mindlessly. I'm not going to say, well, I'm going to use the serotonin pathway here to stop you from a migraine, because my goal is to have everything constrict again. That's not how my brain is working. As I said in the previous episode, if you're having an active migraine, I will use that medication short term. Absolutely. But it is laziness on my part to keep you there. Think about this from my perspective. As a physician going into the room, just stabilizing you should only be one part of what I do. It should never be the sum of what I do. There's certain specialties that they should be stabilizing. That's emergency room and triages. And okay, but if I'm providing you care and you're giving me your trust, I shouldn't be thinking one-dimensionally with you, meaning this is what you have, I give you this, that does that, you're good. No. Why do you have the migraine with aura? Why do you have the migraine? I need to understand deeper into the individual the best that I can. And while they're still kind of fishing out, fishing out, because sometimes in research, it looks like just fishing, they just study after study after study, waiting until they catch something, I can't wait on that. We know that serotonin plays a role with migraines. We know it has a chance that it's associated with the vasoconstriction and dilation component of migraines. We know that plays a role, but we also know there's other aspects of serotonin in the mind and what it does in the brain and neurologically. So I'm still going to run the lab. I'm still going to see, are you low in serotonin? Then I want to be a smart doctor for you and figure out why you're not making serotonin. Because think of this, for love of Pete, if you're not making serotonin, right, your serotonin is low, and all I do is give you a Triptan class of medicine, what else am I missing? Serotonin plays a big role in gut health, your intestinal mobility. Oh yeah. What about other things? Serotonin. We all know about serotonin for depression. Did I fix any of those things by just giving you just that Triptan class of medicine? Nope. What if you're having migraines and you have low-key depression, but you don't tell me about it because you just learn to live with it? I mean, how many women do you know learn to live with their depression? Almost all, right? So that woman coming in for migraines, and I didn't pick up the idea that she has depression, and I didn't go further to understand her, I failed my duty as a physician to you. So I want to understand that pathology better and run the lab. So like I said, if I need to block this migraine with a Triptan class of medicine, I will do so, but I will do so temporarily while I'm trying to figure out the rest of you. I'm going to run all the other labs. What if this is a magnesium deficiency? And me just using the Triptan class of medicine has some benefit, but really the big problem is going to be a magnesium deficit, which is weird because you think about magnesium is a vasodilator. So how's that helping with a migraine? See, this is the dilation constriction thing. We can't always sit hard on that one. We have to kind of think around it as best we can. We have to think about the individual in front of us and the associations of migraine with what types of pathologies. Migraines with people having around their period, or migraines with people with the magnesium deficit, or migraine with people with the serotonin deficit. We always have to think around it. We can't always stick with, well, is it dilating or is it constricting? And we have to be better. We have to be better. One of the ways I like to think I'm being better is understanding serotonin more. As I mentioned, estrogen, when it's dominant, you can affect your ability to make monoamines. You'll see that with women with high estrogen, super physiological levels, they don't have as much serotonin. That serotonin deficit, migraines, that's there. Got it. What else causes serotonin deficits? MTHFR. There's a genetic predisposition. Some of us have this genetic inborn error of metabolism, is methyl tetrahydrofolate reductase. And when you eat, food, you will end up getting, of course, when you're eating a healthy diet, you should get folate in your diet. And then that folate, when it gets into you, it needs to be added a methyl group to it to make it do its job. Now, not everyone is able to add methyl groups like they're supposed to. So some of us don't methylate well, and we end up having less serotonin because of that. So methylation plays a role with generating neurotransmitters such as serotonin. Methylation plays a role with something called homocysteine, which is something that irritates the lining of the arteries and long-term increases the risk for atherosclerosis. People who don't methylate have a lot more problems with liver detoxification pathways. They have issues sometimes with sulfates, histamine intolerance. These things all play a role. They come together. So you see what I'm saying? You have the woman coming in with migraines. I should run an MTHFR panel on her. I should ask her other questions, of course. Family history of heart disease, family history of neurological stuff, family history of depression, fertility issues. These are things I know to ask for around a migraine, because when she's with me, I'm thinking to myself, what's causing her migraine? So I'm going to go down all those roads. I'll ask her about that pathway with serotonin. I'm going to ask her all the different ways that serotonin is deficit in her body to further understand what else could be at play. And then I run that genetic panel based upon that. Same thing with magnesium. Someone comes in that I think is a magnesium deficit. I'm going to ask them symptoms associated with magnesium. If I'm casting the wide net, I'm still getting to learn them. I'm going to ask about magnesium, about serotonin. I'm going to ask about everything because I want to know that woman. This is basic medicine. This is not fancy medicine. This is not elite medicine. This is not rich people's medicine. This is just freaking medicine. This is it. Basic stuff. Nothing I just said was weird. Everything I just said is based in simple human biochemistry and well-known facts about the human body. Nothing weird that I just said in there. Everything's what I just said is exactly it. So I just want you to know you deserve that. Wherever you go to get your medical care, this is the standard that I think should be established for you, because every doctor had to learn what I just described in order to pass their boards. And if they learned it to pass their boards, they should still have it in their head to practice medicine. If not, they get a little refresher, they could still do it. But still, this is not fancy, okay? So I wanted to use that part in there because we do want to look for issues of metabolism of making your serotonin. What else? What else do I want to talk about today? Another area that is not hormonal in nature that could be doing this could be diet. Many of you know this. No one wants to do it. There are foods that we become sensitive to. And some of them could be the amine group of foods. These are certain foods like chocolate, wine, these things, certain cheeses can all push down that pathway that could trigger you having a migraine with histamines. That's entirely possible. And that is valid and is important to go down that road. But it could be other foods as well. Sometimes we have these irregular immune responses to foods. The best way to establish whether a person has a food intolerance is not through lab work. I want you to know blood work for food intolerances is still not accurate, in my opinion, and in my experience. It's something that needs to be researched more and deserves to be researched more. There are companies out there that have good products, and I still use them. But when I use those labs, I know that there's a chance that they're wrong. So I want to tell you the gold standard, the best way of establishing whether a person has a food intolerance or not is the elimination diet. The elimination diet, if you Google it online, it's very straightforward. I mean, it's everywhere. It's a simple diet to do. you take out the primary allergens out of the food, out of your diet for 2 weeks. So, wheat, no dairy, no corn, no soy, no eggs, citrus. And there's a certain degree of personalization I do as well. So the patient presents to clinic with migraines, and I want to know about her diet. I'm going to ask her, what are you eating? I'm going to ask her what she's eating, and I'm not looking. And every time you ask them what they're eating, they always want to tell you all the good things they eat. Yeah, that's not what I need. But I also don't need all the bad things. I need everything. I don't want us to judge what you're eating. I'm looking for patterns. I'm looking for something you're repetitively eating. I'm looking for patterns that you're eating this food frequently, and all of a sudden you're having migraines with it. I want to understand that. And a lot of times these foods, it's not like a peanut allergy. You eat the peanut and all of a sudden you're anaphylactic. That's different. I'm looking for intolerances. It's not always directly associated, because if it was, you'd know, don't eat peanuts because you don't have anaphylaxis. You know, don't eat, that piece of chocolate, you have a migraine right after it. It's not always that clear cut. So as a physician, my goal is to look for a pattern in that 2-week period before they had a migraine and try and understand their diet. So if I see in that pattern certain foods that are not on a traditional elimination diet that are a little weird, I will put that food in there and have them eliminate that as well. So we do a traditional elimination diet for 2 weeks. We have the patient monitor for their headaches and their immune response. So we have the patient do the elimination diet for 2 weeks. And at the end of 2 weeks, we have them keep a record of if they had any migraines during that time, what their symptoms, what they felt like. And then after 2 weeks, we sit down with them, see how they are, and then we give them a reintroduction diet. Every other day, they reintroduce a pure source of one of the foods we eliminated at a pretty healthy amount of it. And the goal of that is to trigger the immune system to give us a more clear response. Is this what they're sensitive to? So you go one at a time down the list of foods you eliminated every other day, introducing them and watching for symptoms. This is a classic way of finding out if someone has a food intolerance. And if a migraine comes after consuming that food, we know that's what that is, because we've isolated it. We've spent time making sure it's clear on both ends, a day before and after. Run that food through your body. See what your body did with it. Did you have a reaction? So elimination diet is another tool that we use in practice. So as we're coming to the close of this series on migraines, the things I wanted you to take home are going to be, these are hormones more often than not with women. You deserve them to be tested. It could be the estrogen levels being too high. It could be the estrogen levels are fluctuating real high and low. It could be due to not ovulating with low progesterone. They often happen together with women. Rarely are they super separated, but they often happen together. But each one contributes to a migraine. And we have to understand which one is really triggering it. And if it's all of them, we need to treat all of them. Like, in other words, help balance down that estrogen, help bring up the progesterone, and then the nutrients that go along with it, as I mentioned in the previous episodes. So you want to think that way about your patients. And then, as I mentioned in today's episode, and I want to repeat this, you don't want your doctor to just assume why you have a migraine. You want your doctor to figure you out. Migraines are debilitating. I know this. My wife has migraines, or used to have migraines when I first met her. I've never had a migraine, but I've seen it. I witnessed it. It's hard, it's painful. And you deserve a person to spend all their gray matter around you. So today's episode is me talking about, the genetic components. Just go over some basic ones, the MTHFR, and then talk about different foods we have an intolerance to and how to elimination diet to figure that out. The next episode, I'm going to sit down and go over all the reels. I'm going to go through all the videos that we've done in the series. I'm going to look for any questions that kind of stand out that some of you have together, or just ones that I know are very common questions we get asked in the question. I'm going to go through each one of those questions and answer them. As always, I appreciate your feedback and I appreciate your participation in this. There are times I sit back and I watch your interaction with each other in the comment section, and you can be so helpful for one another. It's just, I'm very humbled by being a part of that. So I just want to say thank you for those of you who participate in the comment section and putting everything in there that you do. I really do. I really do appreciate you. If you like what I do, like it, press like. And if you think it's valuable to someone that you know, please share it with them. And then always please subscribe. And I look forward to seeing you at the next episode.